average patient, the period between the first appearance of symptoms and an accurate bipolar diagnosis spans 6 to 10 years. The World Health Organization classifies the condition as a top 10 cause of global disability. In clinical practice, the stakes are concrete. The suicide risk for these patients is 15 to 20 times higher than the general population. Early 20th century clinicians like Emil Kraepelin identified the condition as manic depressive illness, but modern diagnostic standards now recognize a broader spectrum. Bipolar 1 is defined by at least one manic episode lasting 7 days or requiring hospitalization. Bipolar 2 consists of at least one major depressive episode paired with hypomania, a less severe state of elevation that does not cause marked functional impairment. Most patients initially present to a clinic during a depressive crash. Consequently, the disease is frequently misdiagnosed as unipolar major depressive disorder. Bipolar disorder requires a dynamic treatment strategy because the underlying neurobiology changes as a patient moves between episodes. Pharmacological intervention is dictated by 3 distinct clinical phases: acute mania, bipolar depression, and maintenance. An agent that prevents relapse in the maintenance phase may have no clinical effect during an episode of acute mania. Prescribing requires a management of narrow therapeutic indices, where the gap between an effective dose and a toxic dose is slim, and the careful navigation of complex drug-drug interactions. Clinical success depends on matching specific molecular mechanisms to a phase-specific pharmacological matrix. Clinicians often mistakenly prescribe standard SSRIs or SNRIs when a bipolar patient seeks help for depression. Using antidepressants alone is an absolute contraindication in bipolar disorder. They act as destabilizers, often precipitating mixed states or rapid cycling, a course defined by 4 or more mood episodes within a single year. This can trigger a manic switch, where the medication drives the patient out of depression directly into a state of acute mania. In the STEP-BD trial, researchers found that adding antidepressants provided no significant benefit over using mood stabilizers alone for bipolar depression. If an antidepressant is used, it must be combined with a concurrent mood stabilizer or second-generation antipsychotic. Acute mania is characterized neurobiologically by a hyperdopaminergic and glutaminergic state that requires rapid chemical suppression. Valproate is a first-line agent that blocks voltage-gated sodium channels and increases the levels of GABA, an inhibitory neurotransmitter that slows down neuronal firing. Use of valproate is strictly limited in women of childbearing potential. The medication carries a 1 to 5% risk of neural tube defects, birth defects of the brain or spine, and can cause cognitive impairment in offspring. The chemical potency required to halt acute mania carries a high risk of systemic and reproductive toxicity. Patients spend the majority of their illness in the bipolar depression phase, which accounts for the highest rates of morbidity. Second-generation antipsychotics like quetiapine and lurasidone are prioritized for their rapid onset of action and relatively low metabolic side effects. Lamotrigine is effective for preventing depressive episodes, but it requires a titration protocol lasting several weeks. This slow pace is mandatory to avoid Stevens-Johnson syndrome, a dermatological emergency that causes the skin to blister and peel. Because of these kinetics, lamotrigine is used for maintenance and prevention, rather than the immediate treatment of an acute depressive crisis. Clinicians often combine these drugs to cover multiple phases of the illness, which creates complex metabolic interactions in the liver. A critical risk arises when combining valproate with lamotrigine. Valproate inhibits the UGT1A4 glucuronidation pathway, the enzymatic process used to clear medications from the body. This inhibition doubles the concentration of lamotrigine in the bloodstream, increasing the risk of Stevens-Johnson syndrome unless the lamotrigine dose is proactively reduced by 50%. Conversely, the drug carbamazepine aggressively induces enzymes that speed up the metabolism of other medications, which can lead to the failure of oral contraceptives. Understanding how these agents alter each other's metabolism is as essential as understanding how they alter mood. Lithium carbonate is a simple elemental ion that remains the foundational treatment for bipolar 1. This element has been used in psychiatric medicine since the 19th century and shows high efficacy across all 3 phases of the illness. At the microscopic level, lithium inhibits second messenger systems, the vital signaling pathways within the neuron, specifically targeting enzymes like IMPase and GSK3-beta. By modulating this internal cellular architecture, lithium provides long-term neuroprotection and helps stabilize the neural network. Beyond mood stabilization, lithium has a unique property. It is the only medication proven to directly reduce suicide mortality. Meta-analyses show that lithium reduces suicide rates by 60%, a benefit that exists independently of its other mood-stabilizing effects. Maintaining this benefit requires keeping serum levels within a narrow therapeutic range of 0.6 to 1.2 milliequivalents per liter. Common over-the-counter NSAIDs like ibuprofen or certain blood pressure medications can interfere with renal clearance, pushing lithium levels into the toxic range. Managing bipolar disorder requires matching molecular mechanisms to specific disease phases, respecting metabolic pathways, and strictly maintaining the margin between stabilization and toxicity.